अभी करता हूँ. किसमें? अच्छा, हाँ हाँ, ओके. Yeah. युवराज इसको बंद कर दो यार, ये वाला दरवाजा बंद कर दो ये वाला. हाँ, सुशील, can you run up? We're starting the session. Okay, good afternoon, guys. Hope you had a good lunch. And you're going to have a good sleep now. Yeah. This was not my talk. This talk was to be given by Ashish Panda. But unfortunately, he had to actually move to Germany in short notice. So he asked me if I could do this talk. This is about lies, damn lies, and myths. Which are there in anesthesia, in ITU, everywhere, okay? But it's there in general public, okay? You know, about anesthesia itself, okay? So this is actually a nice short video.
That's interesting. I heard a lot of negative views of being an anesthesiologist.
That is not true. In fact, I thoroughly enjoy my work.
Oh, really? Most people think anesthesiology. Newspaper.
Nonsense. Anesthesiologists genuinely build rapport with the patients. They go and see the patients at the ward when the patients were the most anxious before surgery. Then, anesthesiologists see the patients again after the surgery to help them with their pain.
But, you see, anesthesiologists have so much free time.
Anesthesiologists are the busiest before and after surgery. During the surgery process, they monitor the patients often.
Oh, okay. But, I heard that to be an anesthesiologist is demanding and requires a long training period.
At least 6 years of training is required to become an anesthesiologist, as this practice of anesthesia embraces great diversity of anesthetic procedure. It ranges from having to administer anesthetics to newborn babies, to elderly patients, from dealing with minor outpatient procedures to heart transplants and brain surgery.
So, what's the main reason that you chose to be an anesthesiologist? As far as I know, being an anesthesiologist is not rewarding or challenging.
In my opinion, the ability to contain and control the patient's pain and anxiety using both communication and medical skills makes for a fulfilling career.
That's fine. So I think all of you identify with this? Yeah, and you know that myth is there not only among the general public, but that's there among the doctors themselves, other specialties. That's how they think about, medicine guys or surgical guys or things. They say, oh, all they do is just give anesthesia and then go to sleep. Okay. But we look at what actually myths are like. Okay. Everybody knows what this is? Isn't it? Yeah, it's not tube light. You might be feeling like a tube light now. After the lunch, everybody feels like tube light. Okay. So yes, this gives us idea. Okay. So bulb, okay, was patented in 1880. And who patented this? Okay, so Thomas Alva Edison. Why is it a myth? Do you think so? It's a myth. Okay. In 1880, okay, when he patented it, said the bulb, the filament is basically made of tungsten. Right? Well, actually, in 1840, somebody had already done it. Okay, except that they had actually used platinum. But we know that platinum is white gold, isn't it? It's very costly. So it won't be very economical to actually have a bulb with platinum in the house. Okay, it will be stolen. Okay, and it will be very costly to produce. Okay, and it was by this guy, Warren de la Rue. Okay, he was from UK. He sounds French and probably is French, but he was settled in UK. Right? So we could say that it's a myth, but it's actually just that it's not a fact. Okay, fact is that bulb was invented by somebody else. Because when you ask who invented a bulb, we always say that it was Thomas Alva Edison, but that's actually not true. What is a myth about? Yeah, Great Wall of China. Absolutely. Okay, so it says that, everybody says, oh, that is the only structure, man-made structure that can be seen from space. But that's not true. As soon as you go 160 feet, you would stop seeing any man-made structures. The only thing you can actually see is lights. Okay. So if you had to look at learning as such, learning includes education, which all we go. Okay, we go to colleges, we go to schools. We practice things which we are taught in schools and medical colleges. Okay, and we look at either do research or read about research. But how do we actually learn all those things? We ask, then we acquire the knowledge. Okay. We then appraise it. Is it necessary for us? Can we use that knowledge? If we think it is applicable to us, we'll apply that knowledge. Then we assess whether it worked for us or not. And then we can go through the full cycle. Okay, that is how we learn. But if we ask, and then we acquire and apply without actually going through the appraisal process of it, then that's where myth will develop. Okay, how does it say? Oh, I learned from Professor so-and-so. He does like this, so I will do it. Okay, he might have been doing it wrong. Or you say, oh, Dr. Shiv told us on the anesthetist group, so we can do it. No, that is not the way. Okay, that's where you need to have critics. Okay, they need to ask you, do you think it's right? Is this how it needs to be done? Okay, so it's very, very important that we do not follow blindly. Okay, otherwise you'll feel like that. You'll feel blindfolded in a room. You don't know where your target is. Okay, so it's very, very important to go through the whole structure, and that's how evidence-based medicine practices come in. We look at evidences, okay, we apply them, we assess them, we appraise them, okay, this happens. So you can either be a leader or you could be a follower. So today what we are going to learn is, I'm just going to give you a few examples of some of the myths which have come into anesthesia, but they may not be truly myths. But what's important that there is obviously limited data which actually supports some of the well-established clinical practices. You see people doing it, you follow it, without knowing what is the basis of that practice or how that practice actually originated. And that's why it's very, very important that we retain a healthy skepticism about our practices or preferences or traditions. Okay, don't believe everything what is said to you. Okay, try to find out what is the truth behind it. Okay. And we said that we should follow evidence-based medicine. Okay, but unfortunately, evidence-based medicine is based on research, and some of this research could be total fraud. Okay. Now, how do you actually believe that? This guy, actually 21 studies he published, okay, and none of these studies was actually, they were done on paper, sitting in his office, okay, churning out paper. He was an expert, okay, he was called by, everybody quoted that studies, and they said, oh, this is the work we need to follow, okay, for pain relief. Don Polderman, okay, recently, okay, about everybody actually started giving beta blockers to whoever comes to the operation theaters, has got a little car, put them on beta blockers. Okay, a lot of his work, again, okay, all fake work. Okay, no proper conducted studies. Okay, and these came into our, not only the literature, okay, guidelines were formed. He was actually part of the European guidelines. Okay, so guidelines is to be followed by everyone. Okay. This guy, anybody know who he is? Joseph Bolt. Okay. Again, can you believe the number of papers, his papers were withdrawn? Huge numbers. Okay. So he did not get any ethical approval in 68 of his papers. Okay, rather they said that when you read through this, he produced something on a bypass, the cardiac bypass, and albumin. He said, oh, compared with albumin. And when they went back, he said, we have not used albumin for the last 20 years. They went to the pharmacy, said, we never issued any albumin for these cases at all. Okay, so total fraud. What is the motive? What is the motive behind this? Because in one of these papers, they actually wanted to know why people do this. Okay. And this was the conclusion of that. Okay. This is all about vanity and self-aggrandizement. Okay. Just to feel great. Okay. So that he could be actually, put up in 5-star hotels, treated as a celebrity, basically. Okay. So this changes our perception. Okay. Of what good researchers could be, because they were actually held in a high esteem, and this is not good. Okay, so if you don't want anyone to find out, don't do it. Okay. You can't do research, don't do it. Doesn't matter you do it. Doesn't make you any greater if you do not do research. You can be a good clinician. You could actually help patients. You don't actually have to be in a big name to be actually be good. So moving on to this man. Okay, he has not done any fraud. Okay, he's not done any fraud. Can anybody tell us what did he do in 1961? Okay, something everybody uses it. Okay. He's the one who described crack-out pressure. So it was Selleck. So he did a study in 26 patients with applying crack-out pressure. And this was a statement. It said crack-out pressure improves patient safety during emergency intubations. Good thing, isn't it? Patient safety. You talk about patient safety today, your paper will be accepted. Okay, so 26 patients. And all of them actually had crack-out pressure applied to them. And he found 23 out of 26 actually did not have any, evidence of aspiration, regurgitation. Okay, but 3 of the patients out of this 26 developed pneumonia when they actually took off the crack-out pressure. They applied crack-out pressure in all of them, but they took it off before the cuff was inflated. And their conclusion was very right. Okay, yes, it does prevent aspiration, so it should be applied. So there were a lot of assumptions here, and obviously the one everybody knows how you actually apply this. Okay, this says the cricoid ring compresses esophagus against the vertebral body. Fantastic. Okay, it went on for a lot of years till somebody said, oh, let's actually look at the esophagus itself. Okay, we do a lot of MRI, CT scans. Okay, let's look at the esophagus. What does it do? Where does it lie? Okay, so they looked at it and they found that the esophagus was actually not lying in the midline at all. Esophagus is actually lying slightly onto the side. Okay, he said if it is lying onto the side, how can it be compressed? Or even if it is compressed, can it be compressed completely? Okay. Even if you look at the constrictor muscles, okay, the esophagus constrictor muscles, okay, they're not lying absolutely in the center. Okay. So if you look at it, what they found was in around 64% of the patient, esophagus is displaced beyond the lateral border of the cricoid. Fine, so things started changing. He says, so people start saying, why should we apply cricoid pressure? What a stupid thing to do when you cannot prevent aspiration, when you can't do it. Okay. Then obviously, the second assumption is that this maneuver will occlude the esophagus completely and thus will prevent regurgitation in emergency situations. But does it do it? There's a lot of literature where aspiration has occurred despite applying cricoid pressure. Then cricoid pressure itself, is it free of any consequences? It's not. Cricoid pressure can cause obstruction or airway collapse, obstruction of the airway if it is not applied. You can find a huge number of papers on what harm it can cause. Okay. So hazards do exist that are not marked, not masked, that are not marked. Okay, just because you got something hazard is marked, okay, fine, you are warned about it. Yeah, but just because there is no mark, it doesn't mean that hazards can't exist. They can be hidden hazards which we are not aware of. And this was actually in the 4th NAP audit. So one of the communications to the authors was, he said they quoted these papers and said, now tell us, we got evidence the esophagus doesn't lie in the center, it can't be compressed, so why should it be used for rapid sequence induction? And the answer was, no, there isn't. There isn't any evidence because when you look at the papers from Rice, okay, even that paper, these were based on the images. You say, oh, cricoid is lying side, so it can't be compressed. But later on, when a paper was done, actually it's published in anesthesia, they said, no, it does. The whole structure can be compressed. As even if the esophagus is lying away from the midline, you can still compress it. It may not be compressed against the vertebral body, but their longus colli muscle, okay, and that can compress it. So another controversy arose. He said, till now we've been saying that it doesn't, and now he's saying it is. And these were MRI studies. So there are different myths, and there are quite a lot of them, as something like this. Okay, invasive monitoring increases hemodynamic stability during induction. Does it? Is there any evidence to it? No, there isn't. Okay. A slow induction increases hemodynamic stability. Okay, so instead of giving the propofol over a minute, if you give it over 2-3 minutes, will it improve the hemodynamic stability? Yes, it will, because patient won't go to sleep. Okay, patient is still awake, so your blood pressure doesn't change, so you give more and more. Okay, so it doesn't. So there isn't any evidence to it. Or the belief that interscalene block should not be given under anesthesia or deep sedation. They say it increases the incidence of injury. Is there evidence to it? But we still follow it. Let's say, like Piyush, we were talking yesterday, or in their area, or in Dubai or Kuwait, they never do blocks sleep. But if you look at UK practice, everybody does them sleep. Okay, is there more incidence of complications coming out from UK? No. So it's a myth. Okay. So to be precise, okay, there are sort of so many practices, we are accepted practices we follow, which may not actually have any basis to them. Okay, so now now EBM is just not about evidence-based medicine. Okay, E can be anything. It can be economy-based medicine, like in India. A lot of people, we talk about limited resource centers. He said, we do it, we give good anesthesia, okay, we get good outcomes. It's not there in the literature, okay, economic-based. It could be experience-based. He said, you probably actually have done more cases of similar thing. Okay, we've done 2,000, 3,000 cases every month or every year. Okay, that is it. So it is not that evidence-based is evidence-based. It could be experience-based or economical-based. Okay. So basically, myths and unproven hypotheses continue to massacre as received knowledge in our specialty. Okay, we will say that, okay, sometimes you say, oh, Professor so-and-so has been doing it for the last 10 years. He's not had any complications, or he's not had any kind of serious consequences to this practice. Okay, that becomes like a known, because that will be followed by generations. Okay, you would teach them, okay, so they will teach others, and it goes on down. Okay, it may not be in the thing, but it is there. Okay, so where does our society comes in? Okay, so the anesthetic society, okay, comes in. For this, we discuss this. Okay, now this evidence-based practice, which is not there, we are experience-based. Okay, this is a very recent one, you guys. Okay, so we actually come from all different places, different cultures. Okay, we all come together. Okay, we discuss our problems. We get solutions to those problems, and something which maybe just be experience-based is becoming an evidence for us. Okay. Thank you very much. Any questions?
Any comments?
Yes. Comments, okay, comments. Guru is my best critic. He's going to criticize. No, that's it. Thanks, Guru.
What way do you think you can convert this experience into evidence? You can give some solution, because
Yeah,
I guess there are a lot of people doing a lot of stuff
yeah.
which is based on experience
That's
based.
true.
But there should be an initiative to try to get it into evidence, because that's what the world believes.
Absolutely, yeah. Because they say if you're not published, then it is not there. That's what it is. So as a society, what we can do is collecting data. For anything to be published, we needed data. And that requires a lot of efforts. And obviously, Guru actually had tried to start that in regional anesthesia. Okay, collecting data, knowing what the experiences are. Obviously, you need to know what are the good outcomes, but we also need to know what are the side effects, or what are the bad effects or consequences, or disasters. Okay, they need to be recorded, because in Indian practice at least, we try to hide things. Okay, you need to come out. He said, we did it. As long as you have managed the patient well, that's fine. But we need to know. We need to actually have a database of things. And that's a very big job. We need to have initiative we can support. People can input data from anywhere. We need software engineers who can actually design us a product where you can actually input that just from a mobile phone, something like a Facebook. Okay, it need to be there. The app need to be there. The moment you actually do a case, you actually just go, it need to be a tick box like thing. You done this, a little bit of freehand this thing, and it goes into a central database. So it can be done. It's not that it's not possible. It is very much possible. Bimon, yeah.
We discussed a lot of things about slow spinal technique.
Yes. And
Isn't it? All of us are having wonderful experience that giving slow spinal does not alter the hemodynamics.
Yeah.
But probably we are lacking in the data part.
Yeah, but we started collecting data, but nobody was sending us, except for Dipti sent some Hetal has sent some. We still got those data is there. But how many cases did we get in the end? That's because it's paper-based. But if you add it on your mobile as an app, it will be very, very easy. So if there is someone in the group who actually can develop apps, we can do it. Or if we grow in society, we get funds over the years, we could actually employ someone to actually do it for us.
Just a comment on post-op ventilation for TO fistulas. I happen to do about 250 TO fistulas in the last 15 years.
Yeah.
And initially we were not ventilating them post-op.
Yeah.
And in the last 8 years we have started ventilating them. And our success rate has, rather the survival rate of the baby has gone up to almost 80 to 85%.
Yeah.
Which is, I feel, better than what the world standards are.
Yeah.
I mean, any comments on that? Because I don't know what goes on in UK or because in India, as I said, nothing is evidence based.
No, that's not. What is evidence based in the end? What the people are doing is they're taking out, they will do a series of 50 cases and publish it. That becomes an evidence. Now you got a series of 1,000 cases, we don't publish it. That is not an evidence. So you see that anything that comes into literature, it might be a case series, it might be a randomized controlled trial, or it could be anything. It could be even case reports. Okay, unless you publish it, it doesn't become. That's why you need to actually have to bring it into the general public, okay, by publishing it. So unless you publish it, it's not there. It's like documents. Yeah. You might have done something. If you do not actually document it, it's not there according to the court. So you can imagine the whole world is a court. Okay, you're not publishing it, it's not there. It is your experience, good experience. Yes. But most important thing, can it be replicated? What are you doing? Can any other person do it safely? Then if that's done, then that becomes an experience-based or evidence-based practice.
That is a basic problem of most private practitioners like me,
yeah,
who are doing cases and not maintaining proper documentation of these sort of things.
Yeah.
Many of us are doing a lot of things. Like in the afternoon, we were discussing something about spinal anesthesia for lab cole. Yeah.
So we will likely have a
there is a session on that, so let's discuss it later.
Dr. Shiv, with the permission, I have a suggestion. Yes. Now that you have opened up this beautiful forum, and people are here from all over India, yes, can something like a multi-center trial start with you all anesthetists taking up one particular topic or one particular work and send them to you, so that, and multi-center here, state-wise, hospital-wise, whatever. Then your number will increase.
It's not an easy job, because if you actually have to do it, you have to go through ethics approval.
Get that?
It's difficult. It's not easy to get ethics approval. It is a big task.
If you're just doing data collection, you're not changing your practice.
Exactly.
Collecting data.
Yeah, that is different. No, you don't need for data collection. You can. We're talking about like doing a randomized controlled trial in multi-center trials. Data collection is fine. Data collection, you can do it. Nobody can question that. Yeah. Yeah, that can be done. That's what we were doing.
But again,
yeah, but you still need to have a consent from the patient to use that data.
that's right. So we will be in trouble if we...
No, that's what happened in Joshin's case. Okay, in some of the cases, that's what happened. That the data was there. No, it is not that he did not actually collect data. A lot of them actually there was no approval from the patient or consent from the patient to actually use that data. So that consent will still be required. That we can create a consent form. That's not a problem. Everybody can get a consent. It's not easy as long as you maintain them. So that can be done. But consent has to be there to use their data.
If it's just an audit process, do you need to...
Even audit now, yes. Even with the audit now, it has to go through a approval process. Even audits are not allowed to be done just like we used to do it. Yeah, you can. We don't know.
Audits, we don't need.
Okay, so you can. There will be loopholes.
As long as you can guarantee
that
identifiable data from the patient,
is not there.
is not there,
Yeah,
or it's not popular.
yeah, that's so. Yeah, so otherwise we can use it from Australia then.
So the freelancers can just not be a part of it then, of any project or anything. I mean, how do they share?
They can be. They can be a part of a registry.
They should be. We should have a system. We should make a system where we can share our experience. There has to be, because that would be the biggest achievement of this group if we could collect all our experience together and then have it in one place and perhaps publish it. But how to do it?
Why is it not coming?
Yeah. See,
Where is
it's
the,
because
slide
it's such a such a varying varied practice and setups.
No, it's there.
I come from an institution I can get, but there are a lot of amongst us also who are doing who have individual practices. There may be a lot of their practices is in nursing homes. Many of them have their own practice. You know, they are in their own hospital. So whose permission do they take? Their own permission? You know, like. Yes, you have to have a proper scrutiny. Yes. So can we have a ethics committee online or something like that as a part of the group? I mean, who will kind of accredit those people? Is it possible? Very difficult. For ethics, for ethics committee. Yes, I know. Of an ethics committee. No, if there are amongst the group, if there are people who are accredited in their own institutions to be, so then they come together and they form this. Is that possible? So if whoever it is, but that person has been, you know, he has been labeled as an ethics committee member or whatever. So amongst us, if there are whoever is a ethics committee member in their own institutions, they become the ethics committee of the group. You know, like the TACON. Is that possible? I'm just wondering. You know,
if we got people who actually are
already on a committee, you know, yeah. Say, I am a member of the audit committee from my hospital, so I become a part of that group. If you are ethics committee member, you become a part of that group, and then will the bodies recognize us as a ethics committee? We are a registered. Yes.
So somebody has to regulate an ethics committee, because ethics committee can come together and say, oh, we want this trial go through. It could be unethical. So it is an ethics committee in the UK is regulated by a national ethics committee, which is in turn regulated by the research department of NHS England, which is in turn regulated by Department of Health. So you need a hierarchy. You can't just come together and form an ethics committee. And ethics committee does not have only anaesthetists or healthcare. They have to be lay people. They could be anybody from the road. Yeah, could be anybody.
Now, I just want to suggest one simplified version. Is what I've been discussing with Shiv. Is I'm in the process of developing an app. I can see that 80% of people here are interested in regional anesthetic, but again, none of them are collecting data of any kind. Having a web-based or an app-based registry where I'm speaking with the lawyer in a couple of days, setting up the app and the whole process, getting it legal. It seems that as a part of a web-based registry and in the terms and conditions, we're going to develop all those things. If each individual practitioner can guarantee that the patient identifiable information is not provided, collecting a database registry does not need to go through an audit committee or through the ethics committee approval. So you don't have to go through all those things. Unless you're developing a new idea into a new research, But, collecting data, which can be sometimes as good, because having data from across the world, say, Shiv does, Tushar does regional anesthetics, Senthil does regional anesthetics, you do regional anesthetics. Now we got data from everywhere. You can pick up your own data, compare with overall data.
It's called a registry.
That's exactly what we are developing.
So
now there are web-based registries.
Registry, exactly,
Exactly. But it would give as good, equal kind of information, and that for you to improve your technique or skills, or do something, find out what's going on wrong, can I improve? So there are web-based registries which are hard to enter, but hopefully with the help of Shiv and myself sitting around, we can try to
we'll
form an
yes,
and always,
before having it,
diversify.
rather than having it published, which can come at a later date,
Yeah.
at least it will be one place where all the data from different centers
Yeah,
is available
exactly.
for us to access whether this practice is correct or not correct, whether there are any problems or not.
Yeah,
So,
exactly.
Okay, guys, I
Okay.
think we need to move forward.
yeah,
Otherwise, we will likely.
Dr. Shiv, just one last thing.
Yeah.
I have one suggestion for all of our friends. This was actually discussed at a conference of medical administrators.
Yeah.
What I'm going to say is beyond our domain.
Yeah.
They were saying that rather than having MD students write thesis, it would be better to teach them research methodology. Now, the point I want to raise here, that's not our domain.
Yeah.
Research is something that needs training just the way medical sciences or economics or anything does.
Absolutely. I totally
And
agree.
I think now, as we were discussing, let's start publication. We can improve the quality of publications if we try to learn research. I know the textbooks and things that are available. I'll put it on the site.
Yeah, some people have,
And,
like
that
Tushar
will-
and all have been to those kind of courses. So there
Yes,
are courses
it-
available for that.
It
and
was
we
a full
can-
paper
yeah.
in my MBA
Yeah,
curriculum.
Yeah.
The point is how to collect data, how to utilize data, what are the different types of studies and all these things that will exponentially improve the quality of whatever we do. I mean, how little it may be.
Okay.
So this is my suggestion. I'll put it on the site.
Yeah, thank you very much. Okay, next talk is very
Thank you,
pertinent
Dr.
to
Shiv.
anesthesia.
Thank you for a wonderful job and wonderful talk.
Yeah, Guru. Yeah. Okay, so next talk is actually very pertinent to any anesthetist or intensivist. It's about management of hypertension and diabetes and how it actually affects our outcomes. So this is Surya. He's come all the way from Dubai again, and just for this talk. He's come just for his years later. Thank you.
Thank you, Takun, for giving this opportunity. This hypertension and diabetes, I think these are the most common medical condition encounter in day-to-day practice in our anesthesias. I'll deliver this talk within 20 minutes, so I'll go through the slides a little fast, and I may not be able to discuss everything in detail, but I'll try to give it as a general principle or the approach, how will you approach these patients. So why hypertension we concerned? Because this around 20 to 25% of patients, pre-op patients are hypertensive, and the long-term hypertension leads to end organ damage, especially the heart, hypertensive heart disease, brain, strokes, chronic kidney failures, and hypertension has been implicated as a high risk factor for cardiovascular disease. And we should also, it will alter, chronic hypertension will alter the autoregulation in various organs, especially the heart, coronary circulation, kidney and the brain. And hypertensive patients, there are a lot of associated comorbidities, especially diabetes, obesity, smoking, and it's very difficult to control the perioperative hemodynamics in a chronic hypertensive patients. So there were various risk assessment scoring system where Goldman, Eagle, Ruby, Deskey, Lee, they found that mild to moderate hypertension is not a risk factor for perioperative cardiac complication. Whereas 2007 SEC AHA guideline, they said more than hypertension, more than 180, 110 is a minor clinical predictor for the perioperative cardiac outcome. Whereas in 2014, there was no comment on hypertension. So how will you approach a patient, hypertensive patient, for surgery? These are the general outline. We first do the preoperative evaluation, then try to reduce any preoperative risk factor, then pre-medication, if a patient is anxious or any hypertensive, try to reduce his anxiety, and we'll do the balanced anesthesia technique and with vigilant monitoring and prompt intervention if needed. So pre-op assessment, what are the point we'll focus, mainly the type of surgery, whether it's a minor surgery, major surgery, the surgical duration, type and duration of hypertension, to see the end organ involvement and what treatment patient is receiving and the effectiveness of the treatment, and also to look for any associated comorbidities and to correct it if possible. And hypertension and patient cancellation. Hypertension is one of the most frequent causes of patient cancellation, but do you have to cancel all the hypertensive patient? As per our evidence says, mild to moderate hypertension in absence of target organ damage is not a major risk factor, so you should not cancel it. But if a pure elective case and your BP is in the stage 3, but now the staging has been removed by the Joint Commission, BP more than 180, 110, and it's a pure elective case, you should postpone and try to optimize the BP. If the patient has target organ damage, and if possible, try to optimize the target organ damage and also the comorbid condition. If he has so many comorbid conditions like COPD, smoking, other things that can be optimized, then try to optimize. But this scenario will be changed if patient is coming for a emergency or urgent cases. What are the implications of antihypertensive therapy? The evidence shows there is, as such, there is no direct association between antihypertensive and anesthetic drug. But some antihypertensive might indirectly affect in the perioperative outcome, especially diuretic. Diuretic may cause your dyselectrolytemia, decrease in potassium and magnesium, that may increase the cardiac irritability, and also it may potentiate the muscle relaxation. Beta blocker and clonidine, they might be absent compensatory tachycardia, and there is chances that if you withdraw beta blocker and clonidine abruptly, there is chances that they may produce rebound hypertension. And patients who are on ACE inhibitor or angiotensin receptor blocker, they get a degree of hypotension during the intraoperative period. As per 2014 ACC ASA guideline, they said no need to discontinue any antihypertensive except diuretic. Even ACE inhibitor, they said you can use it. But if you are going to stop it, it's on your clinical judgment. You are not doing any harm. Herbal medicine and this thing and hypertensive, if patient is on any herbal medicine, ideally they should be discontinued at least a week. So how the hemodynamic changes under general anesthesia? Generally during induction and intubation, during the laryngoscopy and intubation, BP tends to rise. In a normotensive patient, it rises by 20 to 30 millimeter and heart rate by 50 to 20 beats per minute. Untreated hypertensive patient, BP may rise up to 90 millimeter and heart rate may by 40 beats per minute. Pre-existing hypertensive, there is more intraoperative BP liability. Patient may go into hypo or hypotension depending upon the surgical and anesthetics stress. What are the effects of perioperative hypertension? The effects are multiple, mainly on the cardiac, in the form of it may decrease the myocardial oxygen supply-demand imbalance and may lead into myocardial ischemia, congestive cardiac failure, or may in the brain it may cause stroke, both hemorrhagic or ischemic stroke, and also kidney, and there is chances that hypertensive patient might bleed more and they may require more blood transfusion. The overall length of stay will be increased. Ultimately, they will end up into increased mortality and morbidity. So what is the approach for perioperative hypertension? The aim should be the prevention. In the prevention, there is 3 C's. You should check, you should control the hypertension and contain. Continue all antihypertensive medication except your diuretic. Anticipate and manage noxious stimuli such as during laryngoscopy, the surgical stress, by aortic clamping or in the carotid surgery. You should anticipate and should blunt the response. And you should continuously monitor your patient and look for other secondary causes of hypertension like thyroid storm, malignant hypothermia, though these are rare but may be dangerous. Intraoperative hypertension is mainly triggered by some noxious stimuli, whether it may be you or the surgeon. Generally, acute rise of more than 20% is considered hypertensive emergency. And you should know that in hypertensive patient there is autoregulation is altered, so you should always prevent the organ hypoperfusion. because this patient may go into hypo and hypertension at any time. Intraoperative stress, you should counteract with opioid, good amount of inhalation agent, either beta blocker, and then also you can use alpha-2 agonists like dexmedetomidine. And also you rule out common precipitating factor and think of rare causes. So I'll go to the next slide. I'll show you what are the common factor. And rarely, if needed, the antihypertensive, IV antihypertensive is rarely needed intraoperatively. So this is the approach for intraoperative hypertension. First, look for common and uncommon precipitating factor. The common factors are awareness, means light anesthesia, airway problem, or problem with ventilation, hypoxia, hypocarbia, surgical factor, or patient is already having pre-existing uncontrolled hypertension. Uncommon causes like pheochromocytoma, thyroid crisis, malignant hypothermia, ICP, raised ICP, or like fluid overload, you should also consider. Then you should confirm your blood pressure, assess the airway and ventilator setting, check for any drug error, assess the depth of anesthesia through clinically, or you can use also BIS. BIS is not, it's a controversial issue. And also check the surgical stimuli, what the surgeon is doing. Then consider opioid bolus, increased sedation or inhalation agent. Consider adrenergic blocker like beta blocker or dexmedetomidine. And rarely, last you can consider antihypertensive therapy. Postoperative period. Postoperative hypertension is generally defined as systolic BP more than 190 or diastolic more than 100 on 2 consecutive reading in post-surgical patient. Generally, it occurs in first 20 minutes of post-op period. Resolution can require up to 3 hours. If left untreated, increased risk of cardiovascular ischemia, MI, and surgical bleeding. So these are the common causes: pre-existing hypertension, pain, bladder distension, emergence, delirium, hypoxia, hypothermia, hypervolemia. Uncommon causes, I think I have already mentioned. Management of postoperative hypertension: first, find out the cause and try to treat the cause. Maintain organ function. To maintain organ function, and also you should monitor the organ function. Like for myocardial ischemia, you will monitor the ECG. For kidney, you will monitor the urine output. Identify and treat hypertensive urgency, emergency. Those patients with acute severe hypertension with impending organ failure, you should identify and treat with proper antihypertensive, preferably IV antihypertensive. And for those hypertensive patients, I think some patients may require post-op monitoring either in the ICU or high dependency unit. What are the available antihypertensive? These are the available antihypertensive. We have nitrate, SNP, esmolol, phentolamine, nitroglycerin, clobidipine, phenol-dopant, labetalol. For acute antihypertensive therapy, you can choose any of the antihypertensive therapy, but preference will be given to those patients who are already on the same group of drugs. Suppose patient is on beta blocker perioperatively, and it's ideal to give a beta blocker in the post-op period if he has hypertensive crisis. And also the degree of urgency. For acute urgency, I think you have to go for faster acting drugs, and for subacute, you can use the slower onset. So to summarize, on hypertension, blood pressure more than 180 over 110 is an elective case. It's better to optimize BP before accepting the case. Moderate hypertension with target organ involvement or there are multiple comorbidities, optimize BP and also try to optimize target organ or comorbidities if it is possible. Poorly controlled hypertension, there is potential for hypo or hypertension in the perioperative period. So aim of perioperative management is prevention. So peri-op hypertension lead to increased cardiovascular, CNS, renal and other end organ damage. So you should always monitor properly the organ function of. Now I will go to the diabetic part. Similar to hypertension, the incidence of diabetes in the surgical patient is up to 25%. And of those 25% of all diabetic, they require some form of surgery at any stage of their life. And the diabetic patient, they experience 5 times more mortality. The mortality rate is 5 times more than the non-diabetic patient. 66% of all complication in the post-op period is complicated by post-op infection in a diabetic patient. And 25% of all death in diabetic is infection related. There is increased incidence of post-op myocardial infarction in diabetic patient. New onset diabetes or acute hyperglycemia in the peri-op period, they have a worse outcome than a chronic diabetic patient. So why diabetic outcome is adverse outcome in diabetes? Because they may go into hypo or hyperglycemia if they are not properly monitored, and they have multiple comorbidities, obesity, or they may have hypertension, dyslipidemia, and there are medication error, especially in the perioperative period when they are converting from either from oral hypoglycemic to insulin. There will be always a risk of medication error, and diabetic patients are prone for infection and vascular complication, either micro or macrovascular, and the poor knowledge of diabetes among staff delivering care, and there is lack of institutional guideline. These are the factors why there is adverse outcome more in diabetes. This was a study published in 2002. They have found that new onset hyperglycemia is linked to the highest rate of in-hospital mortality, whether it's in ICU or non-ICU setup. So what's the harm with blood sugar? Blood sugar more than 11.1 millimole. Actually it comes around 180, 190 milligram. So it's the renal threshold for glycosuria in a normal GFR. That leads to dehydration, electrolyte imbalance, also hyperglycemia, impaired WBC function, that leads the impaired chemotaxis, phagocytosis, that impair wound healing, also the fibroblast proliferation will be inhibited. With increasing blood glucose, there is chances the patient may lead into metabolic complication like diabetic ketoacidosis or HONC. This was a study published in 2013, this annual surgery. This was a retrospective study, the importance of perioperative glycemic control in general surgery, a report from Surgical Care and Outcome Assessment Program. This was a multicentric retrospective analysis, and their patients were 11,633 patients. What they found, in a multivariate logistic regression analysis, they found the infection without insulin and infection with insulin. See, the use of insulin has reduced the rate of infection, the death rate, and the perioperative operative intervention without insulin and with insulin. There was lot of difference. So they concluded that even a diabetic or a non-diabetic patient, the acute hyperglycemia has worse outcome, and patient with hyperglycemia plus insulin, the outcome was almost similar to those patients with normoglycemia. And this was a study in 2006. This was a nice sugar study. Everybody knows that. This was a tight glucose control, and they found that the intensive glucose control therapy was harmful. It ends up into a lot of hypoglycemia and sequelae. So what are the aim of perioperative glycemic control? Is to avoid hypoglycemia, prevent acute complication of hyperglycemia, and maintain normoglycemia. The ultimate aim is to produce equivalent outcome as in non-diabetic normoglycemic patient. Why is perioperative glycemic control difficult? Because there are altered glucose input, such as patient is NPO, changes in bowel motility, level of consciousness, patient might be in enteral or parenteral nutrition. There will be altered hypoglycemic therapy. They cannot use oral hypoglycemic agent. Subcutaneous insulin may have different absorption profile because patient may be in hypothermic. There may be decreased blood flow to subcutaneous tissue. Altered glucose hemostasis, insulin resistance or insulopenic state because of increased counter-regulation, regulatory hormone, decreased ambulation, it's a catabolic state, and the other drugs like steroid. So to evaluate this diabetic patient, what are the key questions? How we are going to evaluate? We'll go for the type of diabetes, whether it's insulin-treated diabetes or patient on oral hypoglycemic agent, and also see the glycemic control, how we can check it. We can show it through the glycosylated hemoglobin. Hypoglycemia awareness, whether patient is aware that when he had hypoglycemia. Chronic diabetic complication, mainly the nephropathy, and neuropathy, stiff joint syndrome. There are lots of lists on it. Comorbid condition, timing and nature of surgery, whether it's a minor procedure or major procedure. Generally, for diabetic patient, minor procedure is defined where patient is not expected to miss more than one meal. And the expected NPO period, both pre-procedure and post-procedure, and the anesthetics techniques, which is regional or general anesthesia. And also, you should ask the question, can it be managed with modification of usual diabetic medication or insulin infusion? So, general preoperative management, these are the golden rule. Ideally, these patients should be posted as morning first case. We should hold the oral hypoglycemic agent or regular insulin on the day of surgery, regular blood glucose estimation, avoid hypoglycemia. Also try to avoid prolonged fasting in those patients. No rule of sliding scale, and there should be low threshold for insulin glucose infusion and should start whenever needed. The choice of technique, whether general or regional, there is no evidence of superiority of whether general or regional is superior to one another. The choice depends on the type of surgery, existing end organ pathology, and the patient and the anesthetics of the surgeon preference. These are some of the diabetic complications and anesthetic consideration, such as atherosclerotic vascular disease. These patients are prone for MI, stroke, neuropathy. There is chances of pressure ulcer, thermal injury, autonomic instability, nephropathy, renal insufficiency, retinopathy, limited visual acuity, passenger chance of high risk transfer, delirium, gastroparesis, high risk for aspiration, stiff joint syndrome, difficult airway. Patient on oral hypoglycemic agent, ideally the day before surgery, as per the latest guideline, they should continue. Earlier they were telling you should stop it 48 to 72 hours before surgery, but new guidelines says they should continue till day before surgery, hold on the day of surgery, and do fasting blood glucose, blood sugar, and regular blood sugar during intra and post procedure. For minor surgery, regular blood glucose estimation and try to resume oral hypoglycemic agent as soon as possible, preferably within 4 hours of the surgery. If patient is on more than one oral hypoglycemic agent, you should treat as a type 1 diabetes, that is patient on insulin, and this patient they should be given insulin glucose infusion for major procedure. And insulin glucose infusion for major procedure on prolonged, or if the patient is on prolonged fasting or patient has high glucose at any point. Those actually the high glucose varies from different guideline. NHS guidelines they says up to 12 you can wait, whereas the Australian guideline they said 10 millimole mercury is the threshold for starting insulin. Ideally, each institute they should make their own protocol and they should stick to one value, and they should follow that. If patient on insulin for minor procedure, day before surgery, you should receive the usual insulin, omit morning insulin for morning list. For evening list, you can be given breakfast plus insulin, and they should fasting blood sugar and every hourly blood sugar estimation during the intraoperative period. For minor procedure, this patient, the procedure can be done in the early morning and they can have their late breakfast with their usual insulin. And there should be low threshold for insulin glucose at any point if blood sugar is found to be high. Then who require insulin glucose infusion perioperatively? As a general rule, these patients with type 1 diabetes for major surgery, they should be put on insulin glucose infusion. Type 2 diabetes for major or complicated surgery with expected prolonged fasting period, they should also be put on insulin glucose infusion. Whether type 1 or type 2 diabetes with persistently high sugar, even for minor surgery, you should consider for insulin glucose infusion. And those patients who are expected to have prolonged NPO status, they should also be put on insulin glucose. So patient on insulin for major procedure, day before surgery, usual insulin regime. On the day of surgery, insulin dose actually depends on patient usual regime and the time of surgery. So if patient is on basal bolus infusion, patient may continue long-acting insulin as usual or in reduced dose, and hold short-acting pre-meal boluses according to the fasting status. Fasting and regular blood glucose levels should be monitored both pre, intra, and post-op. Insulin glucose infusion should be started either pre-operatively or immediately before induction of. So what will be the dose of insulin? There is a lot of calculation how to calculate the dose. This one simple regime is to determine the blood glucose level in milligram divided by 100 or to 150. If patient is obese, diabetic, then you should take 100, or otherwise as a general rule you can use 150. Or if patient is on steroid, you should use 100. Another method is to calculate total daily dose of insulin. What the patient is getting pre-operatively, you can calculate the total daily dose. You can divide by 24. Again, that should be divided by 2. That will tell you the unit of insulin per hour. Sliding scale insulin is discouraged, and during intraoperative period, actually a minimum 1 hourly blood glucose should be measured. If the glucose is fluctuating, you can use 30-minute interval, and you should titrate insulin according to the blood glucose level. BMI, type of diabetic, drug, these all alter the insulin dosing regime. So how to give the insulin glucose infusion? Insulin infusion should be always be packed with glucose solution, piggyback with glucose solution. But there are a lot of variation for this use of insulin in perioperative period. I think last year there was one review article from NHS. They analyzed, they found there are more than 20 protocol for insulin glucose infusion, whereas NHS they recommend 5% dextrose with half saline, with potassium chloride 0.15 to 0.3 millimole, whereas the Australian guideline, they have not said specifically the solution, but they say should be the dextrose solution and should be decided according to the hospital practice. If patient is put on insulin glucose infusion, ideally once or twice daily, you should measure the potassium level. But this should be the glucose solution should be only with used as a maintenance fluid. The replacement fluid should be always be finger-elected. Preferably, insulin glucose infusion should be given through the syringe and infusion pump with a one-way check valve. Each institute should make their own infusion regime or protocol. For post-operative, switch to usual medicine once the patient is eating well, but don't stop insulin glucose infusion suddenly. You should always overlap with the patient medication and should stop 1 to 2 hours after starting his usual medication. And those patients who are on oral hypoglycemic agent, you can slowly increase the oral hypoglycemic agent as per this per oral status, renal and liver function improve. Metformin, if you are suspecting this, there is renal insult, should not be restarted unless the renal function has improved. There is no sliding scale based or supplemental insulin based on total daily dose. That means if patient during intraoperative period, patient has consumed this much of insulin, that dosing you should not use for the postoperative period to calculate the insulin requirement. So to summarize, the main aim in the perioperative diabetic management is the prevention, optimize glycemic control, is preferable in elective cases, diabetic related complication, try to identify and optimize, address associated comorbidities, you define your target blood sugar. For minor procedure, you should try to minimize interruption of the patient usual medication, and insulin glucose infusion, best way to maintain normoglycemia in the perioperative period. Each institute should make their own protocol and should follow it. So what is the take-home message? Try to keep it simple, address this key question, prevention again, monitor blood glucose very frequently, low threshold for insulin, avoid sliding scale, and diabetes education and long-term management. Thank you.
Just one comment. I want to congratulate delegates on that side. They were more awake than this side. Thank you. Use the
private setup, so mostly we cannot refuse cases. And we have some patients who are hypertensive whom we have to take, not 180 by 110, around 170, 160 systolic. And the oncosurgeon asks for induced hypotension, especially during his flaps. Now, if I can only reduce the BP to 20% of the previous value because I don't know his auto-regulation map and all. But they look at the monitor and they say, map to 60 se upar hai aur karo niche, like because I'm an infant in the private world. So can you guide me on how can I assess? And
Do you
how
put arterial lines?
sir, in this hospital there is no transducer.
Okay. It
But
will be easy if you put arterial lines. You just put
yes, sir.
arterial line up.
Yes.
Transducer.
Transducer up down.
Yeah,
So we used to do that in
non-invasive, you can always say it is very inaccurate.
Sir, I also want to be truthful and say what I do. I give him NTG 50 to 100 mics boluses every time because I don't have an arterial line and I don't want to start an infusion.
If somebody
What
asks
should
me,
I
I
do?
just turn the monitor away from the surgeons.
So वो भी तो मुश्किल.
Yeah, you can try that as well.
So वो भी मुश्किल.
Don't let them see the monitors.
So what should we?
Tell them in future if you ask me to anesthetize a hypertensive patient, I'll refuse. So then they'll stop cribbing.
Ma'am, the hospitals.
No, actually, tell him to look at the bleeding side. If there is no bleeding, there is no. He doesn't need to look at the reading. He needs to see operating field. And if there is a sufficient hemostasis, I don't think you need to tell him to bother about the readings.
Okay.
You can tell him, look at your surgical side. Are you happy or not?
Okay.
That's the main thing.
Just one question. Now,
the main concern is you drop your blood pressure. You must be able to explain to your surgeon, like, the issue is his risk of perioperative infarct is going to be high, he's going to stroke out. And as an anesthetist, in real world, you probably will leave the patient too, and he will have to top it. So that'll probably get the balance of equations fine.
yeah. Just one question. Now, what do you think that patient's sleeping blood pressure would be? You said a blood pressure number, say 160, 110.
Yeah.
What do you think when he sleeps? I mean, without those vivid dreams, I guess. I mean, just normal.
Maybe.
What do you think his blood pressure might be?
Maybe 140.
So you can keep that as baseline.
You have a guideline 20% lesser MAP. You are getting MAP in the beginning, and you reduce by 20%.
Okay.
Tell him to look at the surgical site. If he is okay, then there should not be a problem. If there is a bleeding, then only they complain. Otherwise, they don't. And secondly, before they put a flap, in fact, they ask it to stop it so that they can actually see how much is the bleeding.
During the hemorrhage.
Yeah. So their major concern is site, how it is looking.
Yes,
so if you have a 20% lesser MAP, if you have got a bleeding control, there should not be a problem.
Okay. Dr. Hazi?
Yes, usually we refuse the case. You should not do the case, and we are here to serve the patient, actually, to take care of the patient, not of the surgeon. So in any way, I would not do this case in a small private hospital.
Thank you.
Just
One more. Can I have one? So you said about ACE inhibitors and ARBs to be continued. I mean, we are still stopping ACE inhibitors and ARBs, especially under regionals.
I would always, not take it as a blanket. I would always look at the patient's blood pressure, and if it is on the normotensive side, I would tend to stop it, because I can always deal with a little bit of hypertension intra-op, but hypotension is difficult to manage and it's more dangerous. And the other thing I just wanted to just talk about, just mention is there's a lot of talk about pulse pressure hypertension these days. Although every few years they come out with new things, but pulse pressure hypertension of more than 80 millimeters of mercury is considered quite dangerous, where you have a systolic hypertension and a diastolic hypertension is more deleterious to the heart. So that is a situation one should be very scared of, or not scared of, but that is something that one should be aware of, that a pulse pressure hypertension is bad and that needs to be handled more carefully. And but yes, I agree with you. Like ARBs, and I just wanted to share one case. Recently, we had a patient for hepatectomy posted. This patient on her pre-op physician examination was detected to be hypertensive. Just 2-3 days before. Just 3 days before surgery was started on telmisartan, which is a long-acting drug and a diuretic. And then the surgeons quickly posted her for surgery, and she came. And I think there was a little miscommunication. The cardiologist's note was not seen, and the patient, we didn't know that the patient had taken. And intra-op, the whole day, we just struggled with hypotension in this patient. I mean, struggled so badly that we had to start her on NORAD. And it became, and as it is, like as with the hepatectomy progress, patient anyway become a little acidotic and so many other problems. So I think we need to see patients, assess them, and unless if the BP is on the higher side, only then continue it.
Especially with regionals, we face quite a lot of problems when you don't stop the drug. And according to JNC 8 guidelines, that is the topmost priority, ACE inhibitors and ARBs. So we see almost all the patients coming up with ACE inhibitors and ARBs these days for surgery.
Transplants also, the kidney transplant patients, they would always be on these drugs, and then if they take it in the morning and then post reperfusion, they always want the blood pressure to be, rocking, like they say. We want a rocking blood pressure to see the kidney perfusion, good perfusion, and it becomes very difficult sometimes.
Thank you.
I think we have discussed this topic quite a few times on the group. And the new, absolutely. Both, they all come in the same group, ARBs or ACIs. They're the same.
Are to be stopped 24 hours.
Yes, absolutely. And the only indication is that if the patient is in heart failure, smaller doses you continue them. Otherwise, you don't have to actually continue them.
And coming to that, the drug of choice for such a hypertension is said to be vasopressin.
Yeah, Manisha, you wanted to say something here?
Well, for ACE inhibitors, I think. It is well known that we should stop it if they are on ACE inhibitors for high blood pressure. But if you're on ACE inhibitors for failure, then we should continue.
That's what it said.
And the other thing I want to ask is, the speaker just mentioned about sliding scale for insulin.
Yeah.
Why do we need to avoid it?
No. This is for the theaters. I think sliding scales are still used in the ITUs, but I think for the theaters, because patient go back to the ward. You can't continue the sliding scale in the ward. They need to go back on something like dextrose insulin. So that's why I think the safety of the GKI is better than having them on sliding scales. A lot of the wards will not take just separate glucose and this thing. I have had that problem. We've had problems where the glucose drip stopped. Like insulin was running, patient came with severe hyperglycemia. Blood sugar is almost not recordable. So you don't want that kind of situation. So I think for the wards, it's safer to have GKI, whereas in the IT, it's fine to actually have sliding scales.
I think we'll move on to next topic, and it will be a good thing that we can, on the Facebook forum over the next few weeks, each of these topics can come up, and Shiv can set it up, and then we can all discuss.
The next topic was perioperative ischemia. This was to be by Dr. Hassan and by Vikas Gulia, and as I've told you, Vikas Gulia's dad actually had a hemorrhagic stroke yesterday night, so he can't be here. So what we'll do is Dr. Hassan will actually take us through the cardiac part of it. Imagine that he's got a referral of a patient who's developed a myocardial ischemia during the operation. And how he's going to continue. Okay, so we got Chitra now and Gurunath as our moderators. Thank you, Dr. Hassan. Thank you.
Sure. How much may I?
Guru.
May I?
Yeah, please. Start.
Thank you. I think I made a good impression on the eco part. I hope I continue to keep it up. It's a matter now of a bit of a challenge. No, I'm still awake. Thank you. And okay, I'll try to keep all of you. I'll try to keep all of you awake. Let me see. Okay, So yes, it was Dr. Gulia who had, and we had agreed upon together that I'll take just around 5 minutes, give a bit of an introduction, and then he will take over the rest. But having lost most of my hair, I had kept a full lecture also ready. Okay, so knowing sometimes things go wrong, and then you get a few more claps and all that, so one enjoys. Yeah. So thank you. So it happened that the second topic which was selected and told for me to be taken over was this. So yes, it's a very interesting situation, and as Dr. Shiv was telling that you see, we have faced multiple number of times very, very odd situations, and lucky for the anesthetist, they just come, okay, they make a sign and say, okay, go ahead, or okay, cancel, whatever. So, okay, go ahead or sign, and then they just move out. Patient taken, everything goes fine. Sometimes they come back and tell thank you. If nothing happens and something goes wrong, then they are on the next. You told us to do the surgery. So that's how it is. And so what I did was, I just changed the heading a little bit. Instead of calling it that way, to make it easier, I just named it as Heart and its Likely Problems in Cardiac Surgeries. Help in Non-Cardiac Surgeries. So it's like any time a help is needed, then you call in, and that's what we try to do. Try to give our best and take the part of the responsibility on ourselves, and ask you to either go ahead or cancel. I am one of those who, most of the time, he has disappeared, Piyush. Surya is still there. Yeah, he can support me. So, most of the time, I have given a green signal based on, see, it's not a very easy thing, but a good clinical acumen and a sensible practical experience is the secret to a correct decision making. It's not very difficult. There are multiple tests, you do this, you do that. Ultimately, it comes to your clinical judgment. Judging and anticipating perioperative ischemia in non-cardiac surgeries is partly stressful, but very rewarding. Because we have had situations where so many difficult, he's also sitting there smiling, Partha. Yeah, so we had so many difficult situations where you are just called in and told, we want to take him for surgery. What do I do? Patient has this, patient has that. So, with all available tests and the factor of luck equally exists along with the strength of faith, whatever faith. I think if you go in with these two factors, generally the surgeon will be happy, anesthetist will be happy, and everybody comes out happily along with the patient. I skipped these two. I thought there might be a different audience. So, but I kept this. Yeah, to tell that I am from Hyderabad, and these are the beautiful intricate rock formation, and perioperative assessment as intricate as this rock formation in Hyderabad, my city. Okay, now I will come across, like Dr. Shiv said, 4 of my worst or the best situations, which I had to really deal with, and we faced them, and I am glad to tell that we successfully went through the decisions. I don't know how many wrong decisions I did and how many, I'm not going to tell those, obviously. So see, first one, the first case, 84-year-old lady with fracture femur at 3 a.m. and MI at 7 a.m. Being prepared, she was about to be prepared for this fracture surgery. What do? Take her tell the anesthetist, tell the orthopedician, go ahead, take it. And to add to the flavor, it was about 7-8 years back. Who was this? Guess? Ay, that's right. Mother-in-law. My wife is sitting there. It was the mother-in-law. And I had to take up this decision. She was at Hyderabad Apollo, and we had to decide what to do for her next. The orthopedician said the cardiologist will decide. The cardiologist thought, and they left it on me. The cardiologist thought that if I leave her like this, in 3 weeks' time, they said we'll wait for 3 weeks more, or at least 3 weeks. So by then she would be bedridden and probably so many complications will happen. So what do we do next? We called in the local cardiologist who was there. I was not working there. So we called in the local cardiologist. That local cardiologist took her immediately to the cath lab, did the one stent was required, he did that. Still, what to do? Okay, stented, but what do you do? And you have a drug-eluting stent. So yet another issue. So what to do? We did take up the challenge. Patient was operated. She is still going around and everything is fine. So this is the difficult situation you come across. Second situation, 64 years old, 9 months post drug-eluted stent, needs urgent urological surgery. Urological surgery is a high bleed surgery. What to do for this? This came, and these are all live situations which we faced and we had to deal with them. What do we do here? It's a 9-month DES. Now, the guidelines and what we were talking of, guidelines, myths, lies, damn lies, all those things are included also in some of the guidelines. Yeah. So what to do? Do you operate or you don't operate? And so you ask the surgeon, is the surgery essential? It is required or not required? Yes, required. Okay. Drug-eluted stent, 9 months. 3 months remaining. So go ahead. Do it. There is no problem. What will happen in the worst? You can stop the dual platelet for a while, restart it later. There may be disagreement here and people may say, oh, well, it's not the right. But the cardiologist has to give an opinion. Now, either he shies away and says, no, sorry, don't do it. Okay, that's the easiest solution. Or takes up the challenge. A third case. This was for me one of the most challenging situations. This happened in the pre-thrombolytic era, in fact. 43-year-old Mr. C underwent a urological surgery. On the table, the surgeon and the anesthetist call. They were just closing. And they called and said that patient developed an acute ST elevation MI. What to do? Brought to the ICU side. And there, patient developed VT, VF, tuck, shock started, everything done. Okay, patient sort of stabilizes. Now what to do? Do you thrombolize or not thrombolize? He went through a very rough situation. At times, you have to take up the challenge. Because now the question was, if he keeps getting, and he was getting recurrent VT and VF, only option left is try to open the artery. If there's a cath lab available, different. No cath lab available, no thrombolysis. Thrombolysis available. Thrombolized. Patient went back home walking. Yet another. An 85-year-old RTA with history of MI, about 6 months back, multiple fractures. He developed a road traffic accident. What do you do? Operate or don't operate? Operate. Yeah. After all, it is 6 months. Go ahead, even with multiple. The question was also that the patient, on the day of surgery, developed atrial fibrillation. What to do? Still go ahead, operate. Atrial fibrillation is not an issue. Go ahead and operate. Maximum you can do is to give a drug which might revert the patient back to normal sinus. Done and fine. Last of it was as related to basically the guidelines. Now, guidelines are guidelines. Guidelines are not bind lines. You don't get bind by the guidelines. This is a 40-year-old lady with hyperparathyroidism, hypercalcemia. Brown tumor is not really most of us know, I think. Yeah, brown tumor happens around the hip or somewhere. It's not malignant, but it happens due to hypercalcemia. And the patient was unable to even walk. She develops a non-ST elevation MI. The guidelines say wait for 6 months. She was not able to walk. She had become invalid all the time on the bed. A young lady. So we operated. Things went fine. So guidelines need not always be guidelines. Now, coming to the... Just some water. Can I?
I'll get it for you.
So you could see that in a preoperative assessment, this gentleman says, get me the risk factors. And the risk factors were, the reply came that it's still downloading. So if you want to go on the risk factors, there is no end to it. It can go on and on and on. But you have to make some decisions and go ahead with things. Now, the major goal is to assess the risk of myocardial infarction, heart failure, or both, which are most common causes of morbidity and mortality with non-cardiac surgery. Mortality rate of patients with perioperative MI is substantial, ranging from 30 to 50%. Now, conversely, there are very few cases in which the surgical outcomes and treatments are affected by extensive preoperative cardiac testing. So in brief, it is that for a test to be considered useful, it should be accurate, influence outcome, and have a favorable risk-benefit ratio. Now, I wanted to end my talk at this, but I will not. But this is just our CCU. The gentleman here, these are my other young colleagues. This is another gentleman who had come to visit and see us. So this is our CCU where we work. And that's where I thought I will hand over the mic to the young blood, Dr. Vikas Gulia, who is not here. Then, if that is the case, I have to continue. Then the continuation is that help in non-cardiac surgery is related, age-related, chronic diseases, which Surjia just mentioned, mainly the diabetes and hypertension. We are going to cover the coronary artery, functional status, medical therapy, implantable devices, previous surgeries. But coming to really I'll try to go fast on this. I won't take too much of a time. It depends on the type of surgery, whether it is emergency is emergency. You have to go ahead, whatever the situation. Like the patient who had an MI or even must have had an MI 1 week back, gets a road traffic accident, you have to operate. There is no other option. So it depends on that. But there are some test-related factors the test which you choose should have a good sensitivity and specificity and have effect on its management. Now, here, these are the Goldman multifactorial cardiac risk index. Out of this, don't read the whole thing. It's futile. Read only the first two. If the patient has features to suggest heart failure, carries 11 points. If the patient has had a myocardial infarction in 6 months, carries 10 points. Now that case which we discussed had just around 6 months. He was on the high risk, but then you have to do it sometimes, take the bold step of doing it. So barring these two, the rest of these are unimportant and carry very few points. And the 25 points in the major cardiac event was 9%, 22% of patients in the, here is the whole list. And what you have is the highest risk group is more than 26 points, had a major perioperative cardiac event. And if you add up 10 plus 11 is already 21. So how much of these two out of the 26, these two carry? If you do not find these two things, you are pretty safe. If the patient, how I describe it is, if the patient is sitting on the bed, smiling and talking to you, take him. There's nothing much really which the patient will have. Now, but what they did, taking into, was these revised ones. These revised ones are now being used more than the Goldmans, and these revised ones are a 6-point score index, where you have the revised cardiac index. This is called the RCRI, and these are the ones. High-risk surgery, intrathoracic, intra-abdominal, or suprainguinal vascular. Ischemic heart disease, defined as a history of MI, pathological Q waves of the ECG, use of nitrates, abnormal stress test, or chest pain secondary to ischemic causes. Then the third one, congestive heart failure. Fourth one, cerebrovascular disease. Then diabetes requiring insulin therapy, which he was just talking about. And lastly, preoperative serum creatinine level higher than 2 milligrams. So that is what constitutes, and anyone on the net can go ahead and read it. We don't really need to put too much of time on this, and this is how now the scoring is done. The risk associated with each class was 0.4, 1% and 7% and 11% for patients in class 1, 2, 3 and 4 respectively. What's that? You have a song in your heart. We need to operate or replace with a digitally remastered version. Is that going to be the future, Dr. Shiv?
That's what it means, isn't it?
Yeah. So this is probably... Now, these guidelines are there from the American College of Cardiology, American Heart Association. The same thing, unstable coronary syndromes, unstable or severe angina, decompensate, all of them concentrate and come down to two major things, which is heart failure and a history of ischemic heart disease, MI. Now, this is the table which you can follow up, step 1, step 2, step 3, which deals with emergency or urgency or low risk, sort of planned, unplanned. And accordingly, you can investigate these patients and do whatever is required. Your Okay, this is yet another nice slide which I found, is assessment of your functional status, and that is through the METs, the metabolic equivalents, and you don't need a stress test. You don't need to put the patient on in the non-invasive cardiac lab. You can simply assess them by taking up each one of them. 1 to 4 METs, take care of yourself, eat, dress or use the toilet, walk indoors around the house, walk a block or two on level ground at 2 to 3 miles per hour speed, 3.2 to 4.8 kilometers. And you reach a 4 METs, do light work around the house like dusting or washing dishes. This gives you 4. And I think the anesthetist is very happy if they reach 4 to 6. If somebody is having a 4 to 6 METs, these are perfects. This is no problem at all. From 4 to 10 is no problem. They are all perfect people. Whatever they are, climbing or flight or whatever, all of these, including swimming, going down, this is not what we are interested in. We are interested in the 1 to 4. If 1 to 4 goes around 4 to 5, that's it. He is a good patient. One can easily give a signal to go ahead and operate. Now, we were talking of, Dr. Hazim, yes, morning, of use of echocardiography for pre-operative assessment. Yes, sir, without reading that. Useless. Vimohan was asking about ejection fractions and wall motions and this and that. If you want to assess through an echo, pre-operative assessment, it's not going to work. See this. What is the level A, class 2 level? Class 2. Leave alone class 1. Class 2A evidence is, it is reasonable for patients with dyspnea of unknown origin to undergo pre-operative evaluation of LV function. Level of evidence, C. Okay. It is reasonable for patients with current or prior heart failure with worsening dyspnea or other change in clinical status to undergo pre-operative evaluation of LV function if not performed within 12 months. Level of evidence C. Class 3, reassessment of LV function in clinically stable patients with previously documented cardiomyopathy is not well established. Level of evidence C. And lastly, this is 2B, which is also bad. Class C is routine perioperative evaluation of LV function in the whatever is not. This is class 3. It is of no where you have no evidence of heart failure, nothing. It is just. But in our setup, we have a very high rate of request for pre-operative echos. But the reality is you can manage without it. Okay. Gravity has lowered my chest, my stomach and my butt. Why hasn't it lowered my cholesterol? Okay. Factors affecting the cardiac risk, patient-related, type of surgery. This I will quickly go through because here you have a lot of conditions we have already discussed. The next topic is going to be I think morbid obesity, so I am not going to cover on that. This is a special situation because of the obstructive sleep apnea issues which are dealt with. Okay. Now, you spoke of the myth of beta blockers. Probably somebody thought of this beta blocker concept. How many of us know that how is the heart rate distributed amongst the animal kingdom and us? Any idea? The heart rates? Fixed? 6 for crocodile, I think. Crocodile or elephant? Okay, elephant. And sorry? 9. Hummingbird beats at 600 beats per minute and lives for 5 months. The crocodile or elephant, I am not sure, beats at 6 beats per minute and lives 170 years. Human beings are at around 70. So this brilliant fellow, beta blocker man, must have thought, reduce the heart rate, everybody will be good. But what he forgot was that we are made differently. We are made differently, and I don't think a crocodile can give a lecture here. So that's how it changed. So therefore, the beta blockers have gone into literally disrespect. So no more. That era came, give beta blockers, it's all over. Statins, no role. This again are some of the studies, what you need to do. Now, you had a special interest, Dr. Shiv, in asking for troponins and in a post-operative period. Yes, there are some interesting papers which have come in 2014. And these 2014 papers have said, if you do post-operatively everybody troponin, those who had elevated troponins have a higher 30-day mortality. So yes, up till now, yes, these troponins are playing some role. Now, this is again the same chart on troponin, what happens. End with a life scenario, because it was really an interesting story, and I need to tell that. I was called in, we do temporary pacemaking, so I was called in years back at around 1 a.m. to come to the hospital for a pacing. I was reaching, and in our Gulf area there is a habit or a method of checking people, where they are going, what's happening. So one young fellow stopped me. He said, doctor, your ID. I showed him my ID. He started joking and delaying me. I said, see, I am going for a very important work. Please don't delay me. I'm going. Let me go and do the job. Anyway, after a few jokes, I left. I went, did the pacing, came out. When I came out, the same policeman standing there. I said, what have I done? Did I really do something, some mistake somewhere? What happened? He says, sorry, doctor, this was my father. My father was the one whom you did the pacing on and saved. So he was ever grateful anyway after that. And thank you very much. This was my talk, and back to Kuwait. Thank you. Any questions, anything from your side? Yes, please.
First of all, I'd like to congratulate you. I think as a cardiologist, if I could take you with me to the UK in my hospital, I would. Your wife probably wouldn't let me.
Yeah.
But my question to you is, as a cardiologist, have you had any training or any exposure, or you think training is required for cardiologists who get a lot of referral from anesthetists about perioperative management? Because in my hospital, the cardiologist sends a report, heart's fine, maximally optimized, go ahead. Patients having chest pain in front of me, they are on maximum medications, but what they do not know or they do not understand maybe is what propofol does to your heart, what the inhalation agents do to your heart. So what have you done to prepare yourself with all these risk indices and including anesthesia as a part of it?
No, as far as I could guess or rather talk from my side is that we do an assessment on the patient's cardiac status. I'm not talking of those who are having a chest pain. A chest pain, if it is there, you definitely investigate. see that he doesn't have an MI, be sure, and then let him go. But on the other hand, knowing the effects of the drugs which you are using, the anesthetics which you are using is, I think, an anesthetist's job to know.
See, any patient with chest pain is obviously needing to have some more, investigations that needs to be done.
Yeah.
So, no cardiologist with a patient having chest pain could give a green signal for going ahead for especially non-emergent surgery, because surgery again is divided into emergency and non-emergency and relatively urgent surgery.
And you are talking of UK, right?
I'm talking of UK. You'd be surprised. People tell us that patients maximally optimized. They are dyspneic, chronic heart failure.
Right.
Nothing can be done. They need urgent surgery.
Right.
So we don't get much support, or at least where I am now, and Shiv probably will agree, even in the Royal, to get a cardiologist to understand the anesthetic implications, putting somebody off to sleep, even if their heart, looks okay. Echo, I agree with you. I don't believe in a bedside standard resting echo. It is pointless unless you do a stress echo. I don't know. But I think we face a lot of problem with cardiologists getting to understand the effect of anesthesia.
Could it be legal matters which you are so much concerned
well, the
about?
surgeons refer to the cardiologist for them to give a go-ahead. Then the patients come to us in our clinic, and we struggle to give them a go-ahead, and we cancel them because we don't agree with the cardiologist's point of view.
Because that's the biggest complaint of a surgeon, that the anesthetists don't want to, I'm sorry to use the word, don't want to do it, so they are refusing. So then they hand it over to the cardio side, and the cardio side is left to...
We don't believe in what surgeons say, so like everybody else.
Yeah, so this is sort of a...
Sorry, this will be an ever-going discussion. Can I proceed with the next question, please?
Small question. We had a old lady around 80 years old with hemiparesis for surgery for a breast cancer, and since it's cancer surgery, and the surgeon she had hemiparesis around 1 year back, and mostly thinking that because embolic is common. So I asked for an echo to see if there's any clot, any thrombus, which can also embolize in the perioperative period. And the surgeon was a little reluctant to get echo done, financial issues and all. So, as a cardiologist, what is the probability of a clot being there and a stroke and a perioperative stroke 1 year after the previous episode on anticoagulants?
Stroke
Patient
what? You mean CVA or...
CVA hemiparesis. MCA.
No, but no cardiac history.
Sir, no cardiac history.
If there's no cardiac history, then I would not imagine a...
No, and the patient is not in AF. There's no point.
Yeah.
Okay.
And how do you think it would change your management? If at all, if you are likely to get an echo.
No, if there's an LA clot or something, I would take a consent. There could be perioperative.
It could be a hemorrhagic stroke if she's hypertensive.
Yes,
it could be a hemorrhagic stroke.
Yeah, it could
so
be,
then
could
echo would not really help.
We can go ahead without the echo.
Obviously, if there's no heart failure, see, first of all, you have to decide. I always ask, is the surgery essential?
Yes.
Number one.
Yeah.
If the surgery is essential, does the patient have heart failure?
No.
Does the patient have a history of 6 months, BP normal, sugar normal, creatinine normal? Go ahead.
Okay. Thank you, sir.
Welcome.
Okay, I think, thank you, Gurunath. Thank you,
just one more
Chitra.
question.
Yeah.
No, it's not question. Regarding the cardiologist giving fitness for surgery. Usually what we write for a cardiologist referral is kindly get cardiologist referral for preoperative optimization. We never ask for cardiologist fitness for surgery. That's what we write regularly, because once, a couple of times we were in problem, like we sent them for cardiologist referral and the cardiologist has written. The BP was 110 for lap cholecystectomy, and the cardiologist is an emeritus professor. He has written can be taken only under plain epidural, not under GA.
Yeah. I know that this kind of things go on.
There's another small point that I would like to add, is that now that 12 months period after a drug-eluting stent, that has been got down. If it is a semi-urgent surgery, then it can be done after 6 months, because the mortality difference between 6 months and 12 months is just 1%. So if it is semi-urgent, we can go ahead taking all precautions.
Yeah, there is a new paper and a new guideline.
Yeah,
In fact, the new guidelines have
2014,
come,
yeah.
which have reduced it down drastically. This business of stents and dual platelets. They have drastically reduced the.
And
I didn't come on that because that's very recent, and I didn't want really to touch till it gets further established.
And plain simple angioplasty, you can go ahead with aspirin and do the surgery even within 2 weeks.
Yeah,
So
okay. Thanks, Chitra and Guru. It's time for coffee. We come back in 15 minutes. No more questions.
Thank you.
Thank you very much, Dr. Thank you very much. Thank you very much.
I'll see you tomorrow. I'll come on my time tomorrow. Thank you.
Dinner
ये
still
मेरा
तो आ
नहीं।
रहे हो ना आप?
हाँ, dinner आऊँ।
हाँ।
Dinner आऊँ। I'll be back. For the company.
I don't know.
Announce कर दो।
वो कह रहा 10 मिनट बाद इसकी घड़ी कौन सी 10 मिनट की थी यार? उसको